So moving ahead, what we have seen is a number of them, they go to a Pandit and they wear some nice stones and they try to lead us towards Azoospermia at a point of time. There are few numbers are available. Just call up the number and he'll send somebody and you'll get a semen. Union of Andrology. Or there is something, ejaculatory ducts here. In case they get blocked in the prostate, then what happens? The whole semen, how your examination comes out, don't do for all the patients. This is what I want to tell you, that don't share. Again, they're not my pictures. I don't carry out the scans myself, but Sertoli cell compartment and LH will act upon the hormones are not there. It is HH, and here they will respond R confirmatory and then discontinue the drugs, and within 6 months the things can become better. Typing and by chromosome microdeletions. 2 tests will give you a lot of good answers. So why are these important? They are important because they are genetically transmittable. If somebody has got a Klinefelter syndrome, it may be transmitted. But definitely in case somebody has got Y chromosome microdeletion, there's a high chance of him transmitting it to his children in our population. So I think peripheral karyotyping is the one, which means from the Klinefelter syndrome. And these are few of the problems with the Klinefelter syndrome in the male. These also you have to keep in mind because it's after all your patient. So don't in the male. These also you have to keep in mind because it's after all your patient. So don't ignore him that easily. So in case somebody's got a gross karyotyping abnormalities, then there's a high chance of miscarriages and having children with chromosomal and congenital defects. That also should be kept in mind. So karyotyping is an important test for anyone who's having a problem. Biopsy should be done or not. So cold biopsy has got no role. We find so many people coming to us and they have underwent multiple biopsies. Wherever they go, somebody puts a needle inside. So that should not be done. Cold biopsies got a no role. Cold biopsies either you do or I do. In case a urologist does, he should be doing it in your OT and lab, not outside. So in case you find a sperm, or suppose you find some sperms here, these sperms can immediately be frozen. Because we don't want that. He should undergo another prick. For this biopsy, he'll normally put a 16-gauge needle and then curate it. He'll have bleeding and fibrosis. And then the testis, this part may go bad. So in case so we don't like to repeat FNAC. This is important. The arrest can occur at the level of spermatogonium. It can at a level of primary, secondary, or spermatid level. And the whole chain is having hypospermatogenesis. That can also be occurring. This is a normal picture, as you can find, the basement membrane. These we cover at length for 8 hours. Nearly 8 hours in our classes we talk about these things. For our andrology batch, we cover these things in great length. But here, just covering it in a small way, these are the germ cells and they mature to make the sperms here. That's called spermiation. So the blocks can occur, this is normal, but the blocks can occur at any level. It can occur at this level, can occur at this level, or can occur at primary or secondary spermatids. So the blockages can occur at any level possible, and there can be issues. So here you'll find a picture. You'll find good quality sperms present here. This is the normal biopsy picture. I'm just showing you these things because they're important for you. As we are progressing further in science, we have to move one step ahead. So until you won't know these things, then we can't move ahead. So we can have normal here, we can have hypo, we can have maturation arrest, Sertoli cell only, and seminiferous tubular hyalinization as it occurs in Klinefelter syndrome, very commonly. So these are the things which we have to learn. What is normal, what is hypospermatogenesis, and until we don't know these things, then till that time we won't be able to treat our men well. So just read about these things whenever you get time. In case you need some article, I'll send it to you. Do let me know. So this is how the slides are being interpreted, and it's not very difficult to interpret. Any one of you who are doing cesareans and hysterectomies, and we all know about histology, we should know where the problem is, and accordingly we can treat the person. There can be Sertoli cell only syndrome, or there can be maturation arrest, depending upon where we are. So there are some definitions, there are some pictures, but only thing is that before you go to puncture the patient or to use these sperms in case they are present, we should know where we are actually, and then only we should carry out a ICSI. So these sort of images we have to understand. And then we come to Y chromosome microdeletion. It is normally the Q arm has got 3 genes, azoospermic area is there. And then these are the areas which are normally dilated, they are absent. And this is called azoospermic area. We can have loss of A, B, and C. C, we can normally carry out an ICSI, not much of a problem with care. In A and B, it's difficult to find sperms. Though I will request Dr. Rima to speak about it. I'm so fortunate that she is here today. She can throw some more light. So Y chromosome microdeletions are very common in our population, though very maybe a wrong word, but they're common in the population who is having azoospermias. So they are detected by carrying out a PCR and then, but must know that we have to do these things. Don't move on and start doing the procedures because this can be transmitted. So in case you do an ICSI with such a sperm from area C, then there can be a problem later. So you must do a proper counseling and then only you do it. So deletions of A and B are pretty bad. Nothing much happens here, but C, yes, you can get these sperms, but he will inherit. In case you look at the inheritance part, he will inherit the abnormality. This is one thing I like to throw in front of you. Treatment part, I didn't want to speak much because normally what I've spoken today, it's a long around 10 hours lecture actually. I just want to give you a glimpse, but just know that we can take out sperms from many parts of the testes. But in case we take it from the epididymis, which is congested and dilated, it may be having some DNA damage. In case we take out sperms from the testes, they may be better. They may be having less amount of DNA damage. This you have to know. In normal sperm sample, healthy sperm donor can be 6.2%, DNA damage from testes 9.3%, and in infected sample in the PISA, this is from epididymis, can have high amount of DNA damage. These are a few terms for all the people who are not doing IVF. They may be sounding a bit of Greek, but remember that micro TC, expensive, 1 lakh, but is normally able to get sperms in large number of cases. So in case your patient can afford, till the time we have not done micro TC, don't do donor. In case they can't afford, it's a different issue altogether. Then you can go for donor also. And then we've got other methods, and they all cost somewhere around rupees 25,000, and they work very well. Nothing, some pictures. It's not part of my lecture today because that will be in part 2 when we take next month sometime. So we can just put a needle and take out these sperms. Very simple. This is the case of obstructive azoospermia. Take out his sperms and carry out ICSI. We are very happy. You can find these sperms floating. Multiple sperms are floating. They're good for an ICSI procedure. Put a needle, aspirate. If you don't get with the needle, do an open biopsy. Your own eyes. Here we're not using a microscope. And when we use a microscope here, it becomes a micro TC. That's the only difference. And the price becomes 4 times. So this is how you can do a micro TC, open up everything, pick up good healthy tubules, the shiny ones here, pick them up, and you can tease them in the laboratory like that. That's the way I normally do it under a stereosome microscope. I tease and then cut open the tubules. These are seminiferous tubules. And then you may find sperms hanging somewhere here. And there are a few sperms you definitely are able to get. These are caught. But before this, you should have done the karyotyping and CFTR gene mutation. These sperms, there's a method of doing it. And only thing you should know is that we can do it, and it has been done on daily basis at our centers. Everyone is doing it. Not me, everyone is doing it. Carry out an ICSI. That's it. All the things must come to an end. I'm going to sum it up now. I started at 8:30. I'll take 5 more minutes to summarize everything. Summarization will be from ASRM Guidelines Part 1. That is dealt with the topic well. I like to bring all of you back to the class for some time. Long class, 270 people. What I'm finding is 270 people are logged in for nearly 1 hour. I'm so grateful, both Pooja and me, we are so grateful that you have logged on in such big numbers. My whole team is thankful to you.
So I have a question, sir.
Yes,
TEFNA is a
Ramit,
part of micro-TC?
what, Ramit?
TEFNA, that is testicular extraction.
No, that's a different thing.
Micro-TC.
No, that's a different thing. I'll come to this from, let me finish off from me. 2 minutes. I'll just summarize it. Just give me 1 sec or a few minutes. I just want to summarize it. I want to summarize from the ASRM guidelines now. I want to show people what they have to read in that guideline and what is given in the guidelines. So what I'll do is I've copied from I've taken the snapshot from the guidelines, which you must read today. We'll be giving it to you today. What is azoospermia? That has been defined here. I've already defined for you. What is non-obstructive azoospermia? I have defined for you already. The number has gone to 271. Very nice. And then what is obstructive azoospermia? It is defined here. I'm not going to read this for you. You read this yourself. That's the homework for you. That's a homework for you. All of you must read this and keep this thing in your WhatsApp chat. Open this document anytime. We'll be sending you 3 documents. Part 1, Part 2, summary of the original article and 1 algorithm. So in fact, we'll send you 4 articles today. Read it, keep in your records. We didn't give it to your batch, Ramit, I think so, because that time they had not come. That's what I assumed. So you may not be having it. What are the guidelines? What are the guidelines from ASRM? Guidelines say that do FSH and testosterone for infertile men with all these things. So you must know what the world is recommending and why am I showing you this thing? Because I come to see a panel called Azoospermia panel, and all my friends, sometimes even I just tick Azoospermia panel. That contains FSH, LH, testosterone, karyotyping, Y chromosome, CFTR gene mutation, and bill is 40,000. But nothing is required actually. You may be requiring a test of rupees 500. That's it, and you'll know what the person is having. So please don't do it. This is our social responsibility toward the society. That's the reason we are having these classes. Then azoospermic men should be clinically evaluated to differentiate obstruction from non-obstruction. This you have to know. And then when to carry out karyotyping and Y chromosome macrodeletion. They say all the men with azoospermia can undergo these many tests. But again, not all azoospermias. Not all azoospermias. They should be having elevated FSH levels or a testicular atrophy. In a case of an obstructive azoospermia, when FSH is normal, you should not be doing it. That's what I wanted to convey to you. This is the 3 things, and one more thing. CFTR testing should be done in all the patients who have got vasal agenesis. When the vas difference is not palpable, do it. And one more term they have added this time recently is idiopathic obstructive azoospermia. I'm still not sure about this because I look at when the vas is absent, but they have recommended this also. When you don't know the reason, they may feel that it may be palpable but may not be working. I don't know why they have written this. Probably I think Rima can throw some light over this later as a geneticist. And for the men who harbor CFTR gene mutation, even the female partner should be examined. Truss should not be part of initial evaluation, should not be done in all the cases. But in case a man who's got obstructive azoospermia, only there we should do truss, but these sperms can be acidic, azoospermic, and volume should be low. And the normal testosterone should be there, and the palpable vas difference should be there. I've shown you some pictures of epididymis, of ejaculatory duct. Normally, you can see ejaculatory duct on a truss. You can see seminal vesicles and a vas difference also, a thin fiber. But when there's a back pressure, they become dilated. This algorithm will be sending to you very quickly in some time. It's pretty complicated, but we are concerned with here. So I want this part you ignore. Don't talk about this part. Let's talk about, or this part. We don't talk about that. We talk about azoospermia here. Obstructive, non-obstructive. What to do when? In case we have reasons, we carry out CFTR gene mutation. The congenital causes, vas is absent. Or in case it's non-obstructive, then we carry out Y chromosome and micro-tissue. This is what is the whole thing, the way we progress, and consider diagnostic and therapeutic biopsy. So it's not only diagnostic, it is diagnostic and therapeutic. So what you have to learn, for all my young friends who are there, there's a technique called single sperm vitrification. So until you don't have this technology with you, don't do this in case the patient is bad. But in case you do it and you get 2 or 3 sperms, you can't freeze them. So you have to learn the technology. Your embryologist should know how to do single sperm vitrification, and then you do this. That's the way we normally go around doing it. Now, I will keep the session open for few minutes in case you have any queries. And Dr. Ramit, you had a query.
So my query was regarding micro-TC, sir, TEFNA, that is testicular extraction through fine needle.
No, that is different, madam. That is different, ma'am. That is a different. See, when you use a microscope for TC, or see, TC can be done. There are multiple terms. I'll just show it to you, madam. You can do TC. You can do TISA, you can do open surgical sperm retrieval. This is sort of an extraction. You can do it either blind or you can do open, as I've showed you here. You can put pricks, you can just puncture it. You can do multiple pricks. You can do 8 entry points. Some people do more entry points. They're all a different technology. But when you do micro-TISA, in micro-TISA, we don't actually aspirate. Here, we open the testes. I showed you this picture here. We don't do it ourselves. Our urologist will do. We assist them. For this, you need an operating microscope. So they will look at these shiny things. They are the ones they normally pick up, and they will just pick this up and then cut it. In case any bleeding, they cauterize and they give it to us. This is called micro-TC. Otherwise, you put a needle inside the testes. It's always a blind procedure. We are looking for focal areas of spermatogenesis. In a case of Klinefelter syndrome, where we don't expect many of the sperms to be present, we do multiple needle punctures, hoping that one of the areas are open. And the only difference is that whenever you do any technique like this, money is the main concern. This you can do for less than around 20,000 rupees. And when you go to micro-TISA, you may cross even 1 lakh. So there's the main difference between the two techniques, ma'am.
So what about TEFNA then? Sir, TEFNA?
I beg your pardon?
Sir, TEFNA, that is testicular fine needle aspiration. because it is an alternative method of this method of sperm retrieval, and it is giving good results.
Huh.
That's why I read in one of the articles.
It is very good. We normally do that only. As a gynecs, we do that only. But when we open the testes and do that, all are very good techniques. See, I'm just saying that you need aspirations, but when we do the biopsy under a microscope, that becomes a micro TC. The end point is micro TC. Before this, we can put in the single prick in the epididymis, we can do TISA, aspirate, or we do tissue extraction from testes blindly. They're all blind techniques. But the best method to do this is micro TC. It's one of the guaranteed. So what we normally do is, we always put the needle first in the epididymis. In case we fail, then we go into the TISA. We put in the testes and aspirate. Then we do TESI. We try to, with pressure, we try to extract, because for TISA or for PISA, it can still work with a scalp pain. Scalp pain needle. But once we want to go into the testes thoroughly and make multiple holes in that, we normally use a thicker needle. And then we core. That's called coring. That's sort of a biopsy we are doing. But we're doing it blindly. We don't know where things are lying. But in case you really want to get a sperm, so micro TISA is the option. But I can also tell you that 95% or 98% of people, they become better with the techniques which you're talking about. Only few people who have got high LH, high FSH, who have got probably low TSH, any genetic problem, injury to the testes, or orchitis, low volume testes, they are the ones who benefit with micro TC. Micro TC should not be done for all. It's very expensive, and neither it is required also.
Thank you, sir.
Thank you, ma'am. Thank you.
Thank you, sir, for a wonderful lecture. And I just want to draw your attention towards the chat box. We have few very brilliant questions in the chat box. So, and after that, we can have some few more queries. So can you please open the chat box for a few minutes?
I'll just open.
Yeah, thank you.
I'm not able to see the chat box here. Okay, more.
It's below.
Not what happened today. Can you read the questions for me? It's not showing today on my screen.
Yes, sir, sure. I'll read it for you.
Me.
Thank you, sir. So, sir, there's a question from Dr. Nagpal. Sir, in azoospermia, if going for biopsy, do we freeze the sample if sperm found, or we stimulate patient along with? What if no sperm and patient is stimulated? They say what to do.
Pooja, I got 70 notes in the chat box today.
Yes, sir. Yes, sir. We have large number of questions, and they are very brilliant questions. So, Dr. Nagpal's question, I can summarize. Yes. She wanted to know from us that whether we should do the stimulation of the patient and the TISA parallelly, or we should first diagnose whether the sample is present in the TISA, and then we go for the stimulation.
Very good. It's a very, very nice question. There is no role, absolutely no role of doing diagnostic procedure. No role. I mean, this is a malpractice. See, two bad things I'm seeing nowadays is, which I really feel very hurt. And that prompted me to talk about the male infertility today to all of you. And on next, I think over 2 weeks, I'm going to talk about another things, a few more things which really trouble me. One thing is that everyone nowadays is doing uroflowmetry. Any patient, poor guy who comes with a low sperm count or oligospermia, they do uroflowmetry. I don't know why it is being done. Number one. Second malpractice, I call it a malpractice, is that due to lack of our knowledge, for every patient, LH, FSH, testosterone, and we order for Y chromosome, CFTR, and karyotyping. Bill is 40,000-50,000. Third,
so this yes, sorry, sir.
Is the putting the needle in the testes. Like it's a balloon. Anyone goes, just put a needle in the testes. It's something like doing endometrial biopsy for all the patients. Do you all remember anyone who's my age, 50 plus. You all are very young on my screen. Anyone who's
I am Dr. Rama. I am.
डॉक्टर रमा आप है मेरे साथ में.
I am
आपको याद है
62
मैंने
plus. 62 plus.
ओ वाह, फिर तो मैम आपको पता होगा, for every patient we were doing endometrial biopsy.
Yes, people are doing it.
अभी भी कर रहे हैं. It's a malpractice. So
Senior
don't.
gynecologists are still doing it, sir.
No, not
because there are two purposes. One is this for they are doing mainly for sir genital tuberculosis.
No, genital tuberculosis.
And for that we can take menstrual blood.
Exactly. So when I talk about endometrial, that is endometrial blood aspiration. We don't call it biopsy. When she's bleeding, we are aspirating it, no?
Yes.
Biopsy.
We can take that aspirate of the blood from the cervix.
Exactly, madam. Exactly.
We should not interfere with the cavity as far as possible.
Exactly. So I fully agree with you. So we should never do a biopsy.
Nobody is agreeing in gynae. I am a bit different person and I don't go always with the guidelines that way.
डॉक्टर गीता का छुपी हुई है, डॉक्टर गीता खन्ना, उनको भी इन्वॉल्व करते हैं टॉक के अंदर. So biopsy should not be done, should never be done. This you remember. That should be totally avoided.
So there is very relevant question, and I think there's a first question comes in everybody's mind who is stating this. So the question is when to repeat the sample of azoospermia and when we can confirm that person is azoospermic after like how many tests.
So ये लिखा है डॉक्टर नागपाल ने 300 RPM और G. बड़ा अच्छा सवाल है मैडम आपका. It's a very nice query. It is G. It is not RPM. It is G. It is gravity and not revolutions per minute. Very nice question you have put. और ये लोगों को it's taken me around 3 to 4 years. I had my first talk on WHO. When the WHO guidelines came, I think I was the first or second guy to talk on them in the country. That time I said this. And now 2020 edition is already in a draft, it's come. But still people don't know it is RPM or G. For azoospermia, it is G.
Good morning, sir. So that's what was mentioned in the slide. 3,000.
3,000 G.
G, correct. RPM
is... The centrifuge machine which we have, we can do it in that.
It is in RPM, sir.
No, that's what.
So how do we do it, sir?
That's what correct. This is what I keep telling you guys that for this sort of 300 G, we have to have a centrifuge which can give you 300 G, 3000 G. Normally machines cannot give you. For them, you have a mini centrifuge where you put the sample in a small Eppendorf tubes. Not a 15 ml tube, and then only you can carry out 3000 Gs. Normally our machines are maximum going to around 4000 RPM. They don't go to Gs at all. G means around 3 to 4 times of RPM. So what we hear, how we handle the situation is that we can never achieve 3000 RPMs on our REMI centrifuges. Or all the centrifuge machines we have, they have a limit of around 4000 RPMs. So we can never actually diagnose azoospermia the way WHO wants it. So keeping that in mind, they may be changing this definition now. But to achieve 3000 Gs is not possible on our centrifuge machine, which we use in our laboratories. I fully agree with you.
So when we can say that person is azoospermic?
We normally what we do is
how many?
Two. After 2 testings we can do. In case we have a laboratory centrifuge like SRL and big laboratories, they have got a laboratory Eppendorf centrifuges. So for them it is very easy to go to 3000 Gs. Hamari machines mein nahi hota hai. So for routine gynecologists, diagnosing azoospermia would be a problem. Definitely big problem. But big labs can do, but they don't know that they have to do it. So normally what we do is that we take the semen sample, we put the semen sample in multiple tubes, and we give it a maximum spin what we can do, and do more diligent hunting under the microscope at 20 to 40x. And that's the way we do it. But 3000 Gs, no machine in India, routine machines can't achieve. Agreed.
Right, sir. So there's another very excellent question from Dr. Supriya, and she is asking, please tell me what should be the lower limit of FSH LH to decide hypo and hypo.
The upper limit is 7.4 or 7.6. Lower limit, in case I always wanted to find the lower limit. Lower limit you don't get anywhere, but somewhere you get the figures between 1 and 1.2. You don't get, this is the, below this value, you start thinking that there's a problem. And there is a cutoff of the lower limit should be around 1. This is what I feel, and that's what I follow. That patient is having hypospermatogenesis, FSH, LH, testosterone are low. So my cutoff or at the peak will be around 1. And it is not defined anywhere actually, what should be the cutoff. But less than 1, any value which you get with low LH, low FSH, low testosterone, testicular volume and testicular size smaller, and no sperms, I think it is a case of hypo. Same thing in the females also. In the females also, we don't know the cutoff of LH, FSH. Dr. Geeta, can you comment upon this? Do you have anything in your mind? How do you give a cutoff of LH and FSH in the for female hypo? I know I just called you. I am so sorry for this.
Yeah. The lower limit, definitely we are not very much confident about. That's true. That's true.
And I have tried to find out the lower limit, but no one gives the lower limit specifically. I've never found it. But around 1 ke niche, we start thinking about that.
When it comes in points, when we say
points. Correct. But lower limit का upper limit नहीं पता मैम हमको.
हाँ, ये भी नहीं मालूम.
Cutoff नहीं पता. Cutoff नहीं है हमारे पास में इसका.
We may get eggs there also.
Yeah. So we clinically correlate with multiple factors. Yes.
So there is another very relevant question from Dr. Alka Gehlot, and she's asking if CFTR gene mutation is present in both partners, what further management has to be done?
I think they need a genetic counseling in such a case, first of all, and there's a high chance that they may be then we have to look at some methyl reductase. I don't remember exactly, but they look for some more panel of genes, and then they have to take the counseling and they have to draw some combination of how much is the percent of the child getting. Are they recessive, dominant? I don't have this exact figure with me, but I think they should go to a counselor, because in case it expresses in the child can have pulmonary and multi-organ failures. But I think in case you find both to be positive, don't carry out any investigation in them. I mean, don't carry out any treatment in them. This is what I normally follow. But you send them to a geneticist. That's the right thing to do. I won't be able to answer this query now, because I don't do this part I don't carry out myself.
Right, sir. So there is another question from Dr. Neha, and she's asking dosage of HMG and duration of treatment. When to repeat the semen analysis for such patients?
HH. You should always start giving the baby. Normally we give HCG first. See, बहुत अच्छा सवाल है. Very nice question. Who's put this query? Hello. Whose query
yes, sir.
is this?
So Dr. Neha's queries.
So all of you should now listen to this answer. It's a very relevant query. We don't start managing hypo with HMG directly. Always give HCG first. In hypo, we'll have low LH, we'll have low FSH and low testosterone. And what is the most important hormone for sperm maturity? Can someone tell me?
HCG.
Testosterone. So initially we give HCG. We prime them. We fill the petrol in the car by giving LH. LH will start raising the levels of LH will act upon the Leydig cells and start maturing the Leydig cells, and they start making testosterones. But the levels of testosterone go high. So initially 4 to 5 weeks, 6 weeks, give them only HCG. And after 4 weeks, you add HMG. And HMG, normally we are giving 75 units twice a week, or some people can give 150 units twice a week. That's the way we add them. And minimum 4 to 6 months are required when their levels go high, when the sperms are seen. It takes time. It doesn't happen overnight. It takes 6 months. And when it occurs, don't stop. immediately take a semen sample and freeze. Because you can't give him the hormones lifelong. You can't give him. So in such cases, what we do, since his levels of testosterone are low, his libido, his sexual functionality is also low. So initially we build his sperms, get his sperms, and then sperms are frozen, and then you put him on testosterone supplements so that at least he's able to have more androgenic phenotype, I can say that. But freeze his semen sample immediately. This is very, very important. Many people, what they do is they get few sperms and then they stop it, thinking that it'll continue making it. No, it won't happen. It'll again go to negative side. So freezing is important.
Sir, what is the dose of HCG?
HCG, you can easily give 2000. We are normally giving 2000 BD twice a week. We give HCG 2000 BD, and then, or many people combine HCG with HMG. They give 2000 of HCG plus 150 or 75 of HMG. What I normally follow is that I always give HCG first, prime, so that he starts making androgens, because HCG will contain LH. And LH will act upon the Leydig cells, start making some endogenous testosterone. Then I add HMG. But quite a number of people, they add HCG and HMG together and give it twice a week.
So HCG is twice a week?
Twice, always twice a week, ma'am. Twice.
Okay, okay, sir. Thank you.
Twice a week, ma'am.
So thank you, sir.
So
So there's a
how long do we give?
question.
Yes,
So
ma'am.
there's
How
a
long do we
question
give this?
from
6 months. 6 months we give it.
So is it possible that the patient can conceive spontaneously without any other like
Yes, ma'am. They will conceive.
assisted procedure?
Yeah, correct, ma'am. You're very right, Ramit. You always comes up with those wonderful abstract questions. Always typical of you. You are very right. The levels of see, problem with hypo is what? And testicular failure का problem क्या होता है? Leydig cells are not working. I'm sorry, there's a lot of foreigners would be here, and I somehow go to Hindi. I mean, the Leydig cells are not there. Either they are not there, or they are there but they're not working. What will happen? The levels of testosterone are low, and when testosterone are low, libido is not there. Libido is not there. So what we start doing is that we start giving the patient HMGs. They will start making the hormones, and spontaneously they can also conceive. Because the main thing is that the libido comes back. Now he's able to stay together. Now, a very good drug, which I'm finding again, whenever I normally show a slide called that I don't affiliation to any company. I've not shown it today. I never thought this query will come up. One very good drug is something called melatonin. Melatonin is a drug which has been launched by one of the pharmas. I won't take the name because I don't talk like this. It's a very beautiful drug with 𝐂𝐤 and melatonin. Anyway, it's from Sun Pharma. Sun इनका की दवाई है. 100. I normally didn't want to speak about it, but it's a very good. It's the only drug we have in the country. Melatonin and 𝐂𝐤 combination. 𝐂𝐤 100, melatonin 3 milligram. Melatonin is known to raise levels of FSH in the body, and FSH बढ़ेगा तो फिर it increases the levels of sperms. It also affects the testosterone levels in the body. So I feel this is a very good application of this drug, melatonin and 𝐂𝐤10, in case you combine, which is from Sun Inca, they have launched it a few months back. In case you combine them, and the main advantage is what? When the person has got low libido, they're not having relations. So
Sir, we can give some performance enhancing drugs also?
Just let me finish. Just let me finish. I'm going on a different level altogether. I'll come to you, ma'am. When we give somebody melatonin, his sleep cycle is set. His stress is gone. It's noticed that the people who take melatonin, they sleep well and they are able to perform better when they have morning erections. So multiple things add on here. There's a high chance that stress being gone, melatonin by itself reducing the chance, increasing the levels of testosterone and acting on Sertoli cells, sperm count will increase. So I think melatonin can also be added in such cases, melatonin and 𝐂𝐤. It's a wonderful drug, and it will increase the levels of testosterone and improve and remove stress of reduce libido initially. This is one. And coming to Praveen, you can, yes ma'am, you can give any drug. You can always give him, no, giving him a drug is a very complex thing. Time is 9:59. I've got my appointment at OPD at 10:30. So I'll just cover in small things. The libido enhancing, the drugs for performance drugs you said, na Praveen? This is what
Yes,
you
sir.
wanted.
Yes, sir.
So there are multiple
Erection problem, patient having.
So erection problem वैसा नहीं होता है.
Performance means performance.
So you have to break it into multiple issues. Is it an erection problem, or it is a problem, with premature ejaculation? Number one. Or before that, is it a problem with arousal? So first of all, there are 5 steps to it. First of all, this is a separate lecture we have, but I just, since you brought it out and is relevant. First of all, there has to be some visual, and the visual would be arousal. After arousal is there, then there is a role of prostaglandin and everything, and blood flow. Blood flow increases. Then there's an erection. And after erection, there is the role of penetration, and then comes the in between role of premature ejaculation, and then the orgasm. So these 5 things come together. Normally, we are in habit of giving everyone a Viagra tablet. So it doesn't occur that way. You have to just sit down, talk to the patient, and decide what is the spectrum. In case he doesn't have any arousal, only what will you do? You see, arousal. Dr. Rama, I think you can take you're the right person.
If there is no arousal and this hormonal hypo he is, then we have to give this HCG and then followed by HMG.
Exactly.
Yes, but if there is only psychosexual, then you can give performance enhancing drugs.
But are we combining ED drugs or PME drugs? This we have to see. We may have to add depoxetine to it, or we give only some sort of drug like tadalafil or sildenafil. So we have to see in what combination we have to give him drugs. It's not very simple to just give him any drug and go ahead. It doesn't work like that. So a lot of counseling is required. I think the most complex subject which we face nowadays is, and 8 out of 10 men are having this problem.
Sir, counseling is very, very important.
It's counseling.
Counseling and constant counseling.
Very good. So, sir, if you allow, we can take 1 or 2 queries.
Only one. We have to go to my OPD. I have to leave at 10:15.
Hello, sir.
Right, sir.
Hi.
Hello.
Hi.
Sir, what is the role of clomiphene citrate in this?
Lovely. This is for the next lecture, which I'm having a lot on clomiphene citrate. Clomiphene citrate has got no role in the men who have got raised FSH. Your FSH has to be normal. We keep pumping clomiphene to all that should not be given. When the levels of FSH are low, only then we give clomiphene.
It is for maturation arrest.
Yeah, you can. But clomiphene will increase the spermatogenesis.
Yes.
And for that, it'll get more FSH, endogenous FSH, by causing a blockade. In case levels of FSH are already high, then there is no role of giving somebody clomiphene. This is for the question, one big debate like biopsy or not. I've kept it for the next class on 13th of June on male infertility. But clomiphene, levels of LHFSH should be low.
Yes, sir. So there is a question from Dr. Anjali, and she is asking if a patient, azoospermic patient with FSH 66, LH 25, normal testosterone, normal karyotype, would micro TC yield anything?
Yes, you must give it a chance of around 0 to 30%.
Right, sir. And the small testicle volume, like 50% only of the total.
I've told you one thing, that micro TC, we just can't give anyone. We may find a small foci of normal spermatogenesis. I think anyone who can afford does deserve a micro TC. And many times we find sperms. But getting those sperms, whether we can use them or not, that is not important. But the men, when we do micro TC, I don't do micro TC, my team does it. I limited myself to multiple biopsies, that all, open or closed biopsies, but I don't do microscopy. Even if you find a sperm for the men, you show him the sperm in the video, he's more than happy. Then he may shift to donor. But at least I think sperms should be retrieved in case possible, in case they can afford and they are willing to walk with you. There's so many women, I think all of you may agree that so many women with FSH with AMH of 0.2, 0.3, they have conceived in IVF. So people, things they do work. We shouldn't give a blanket answer, it can't happen. So micro TC should be done. In case people are very keen and you have counseled them properly, and there is no gross karyotyping problem, no gross Y chromosome microdeletion in terms of A and B. When microdel A and B are there, then we should avoid that. One more question.
Right.
Then
Sir, when can we decide that the person should go only for micro TC? Straight away. Because there are only, we feel there are 2 less sperms. How can we decide there are 2 less sperms? And the person should not go in for these multiple pricks, etc. Everything, they are ruled out. Straight
we can never decide.
We can never decide.
We can never decide. There is no cutoff. So for any patient, see, I'm an embryologist also. I do a lot of hunting of sperms. We do multiple things, but I don't do cesareans. So I do this part of the work. Always puncture. What Dr. Amit brought out was a very good thing. She's made few comments. You must make few punctures from testes, and the embryologist will take 15-20 minutes to tease them off. In case we don't get any sperms there, then only we do for MESA. Then only we go for micro TC. Otherwise, you don't go for micro TC directly. Always punctures. You get an answer, no sperms. Then you cut open and take out the whole capsule of the testes.
Sir, so the person should go to straight away a person who can do micro TC.
No, you can't. You should not be doing it also. But with the needle, you may get the focus, and why do you want to bill him so much?
Whosoever can afford for that person,
exactly.
He should go to only that person who can do micro TC.
Even in those cases, we should do biopsy first. We should do biopsy first.
So one last question. So one last question. Sorry, sir. Sir, one very common problem nowadays, like you told, the many of the men who go to gym and they have anabolic steroids, their testosterone levels rise up like anything. FSH also, because so at times, what is the time of reversal of?
6 months it takes.
So I had this similar patient over there, FSH level was also high. So how can we correlate?
Sometimes maybe some other problem he may be having. Normally FSH level should go down in such a case. When testosterone goes very high, FSH should go down. Maybe it's all a mix and match. Maybe something else would have been there in that patient.
Sir, could it be Klinefelter?
Maybe I can't comment. I just can't comment without seeing that patient.
He already had one child. This was second time he was.
Maybe something happened. See, there are multiple things are happening in a man. So I really can't comment without seeing. But simple logic is that when we go to gym, we take in a lot of testosterone. The levels will always go high. They are called exogenous drugs, and they will take around 3 to 6 months for reversal. They will reverse.
One last question, sir.
Last question.
Sir, what are the
yes.
Sir, what are the embryos by retrieving these sperms? So what do you explain to the patient? What is the prognosis? What is the chance of getting good quality embryos that will result in live birth rate or pregnancy rate?
In what, Supriya? I didn't get your query properly. Sorry, I missed it. Can you repeat your query again for me?
Sir, after retrieving sperms, after doing any of these procedures, after retrieval of these sperms, we take the patient up for an ICSI procedure. So what are the chances of getting good quality embryos? Because there is some defect and...
Very good. So, are you an embryologist, Supriya?
Sir, I'm an IVF specialist.
Hi, can you put in a camera?
Yes, sir.
Please camera on kar lo, sab log. So Supriya, the issue is you have to know that the main problem with any type of, Dr. Das, good morning.
Good morning.
So the main
One
issue
query in my mind also after you answer.
Yes, ma'am. So Supriya, issue is that we have to, when we look at the problems in the man, the main issue is DNA fragmentation. I wanted to cover this part on 13th of June. So when the sperm, the DNA fragment, whenever we do an aspiration, we can aspirate from the epididymis or testes, or we can aspirate from the dilated vas sometimes. Am I right or wrong?
Yes, sir.
When a normal person, healthy person gives a semen sample, his DNA fragmentation is around 5 or 6. Cutoff, we take it at around 18 or 19. That's a cutoff for DNA fragmentation. Am I right, Pooja? This is what we follow? 18, 17
Right,
to 18.
sir.
So that's what we follow in our laboratories. When the sample is taken out from the PISA, epididymis, call it a PISA, the sperm numbers are more. It's easier to do. One prick, sperms are out, but their DNA fragmentation is high. As I've told you, plumbing, hai na? I've told you, man is like a plumbing equipment. You put that acid in the tube, the plumbing opens. But in the man, it can't happen like that. We have to put a needle to take out those pumps. Or we cut the two pipes and join them together. Like tuboplasty, which we do. So you can do plasty for the vas or epididymis, or vas and epididymis. Or we turate for the for EDOs, as I've told you. So sperm quality will be the best, but less in number in case we take it out by surgical sperm retrieval. Or even TEFNA, whatever Ramit was saying. When we put needle in the testes and take out the sperms by aspiration, they are less in number, but they are having less DNA fragmentation. So DNA fragmentation is directly proportional to the quality of the embryos. So when we get a sperm from the testes directly, there are multiple papers from Centro Steves, and I plan to send them to you today after the class is over. You will find that DNA fragmentation will be less, and that's when the sperms come from the testes. Why? It's a reason. Block is occurring at epididymis or far further away. Block is occurred here, testes are lying here. Block is occurred due to what? Infections, chlamydia, gonorrhea, tuberculosis, they're all releasing toxins. So the toxins are, majority of them are the reactive oxygen species. They're called ROS. They're the maximum there. So in case you take out sperms from there, ROS also comes. Poor quality sperm. So when you take the sperm from the testes, they are always of better quality. They will give you better chance of getting a good healthy embryo. But here again, घूम के वापस जा रहे हैं हम pre-testicular, post-testicular. When testes are the part of syndrome of pre and testicular problem, this sperm may not be of good quality. Obviously, because there the compartment is affected. But in obstructive azoospermia, this only applies to obstructive azoospermia. Sperms taken from testes, they are of better quality. So nowadays, majority of people are shifting towards the testicular sperm aspiration. What Dr. Amit was saying, very correctly she brought out. Have I answered your query?
Thank you, sir. Yes.
Or have I not? I mean, I don't know. Sometimes I go in my own direction.
No, sir. I got it that the DNA fragmentation is to some extent we can label that for the quality of the embryos, and because of the DNA fragmentation is more in the epididymis, increased ROS that might lead to increased DFI, and the sperms retrieved. Therefore, the sperm retrieved from epididymis might not lead to a better quality.
Good morning, sir. Good morning,
Hi,
sir.
Dr. Manoj. क्या हाल है आपके?
Good, sir.
I'm a good friend.
Your views on sperm sorter, sir?
Sperm?
Sorter.
Sperm sorter.
Police.
Oh, favorite. Yeah. वो तो बिल्कुल, this is our heart. So sperm sorting devices are of, they are made by 2 or 3 companies. So they are called basically microfluidics. So microfluidics are a very good, but microfluidics don't have any role in testicular sperm retrieval, because here these sperms are so less in number that in case I put sperms in a plate here, I don't know how many will be reaching here. They're very good for when the sperm number is good, but large number of them are dead or immotile, then the sperm sorter works. But with few sperms by T7, when you take it out, I feel it may not work. This is my feeling, and it won't work also, because the numbers have to be high for them to form a current and then move for around 3 centimeters. Am I right? Do you agree with me?
Yeah. Thank you.
Thank you, sir.
Thank you.
So, Dr. Pankaj, suppose you are doing microdeletion C type and then you have done the 𝐿C. So do you recommend PGD after that, because the chances of inheritance into fetus?
Das ma'am, before, I've told before, 2-3 तो problem है हमारे पास. Y chromosome microdel, do it before. Cherotyping, do it before. I mean, there is no other condition. CFTR gene mutation. These 3 you rule out, and don't rule out these in every patient. So don't do this paneling wala concept. I have told all these companies, don't make panels.
No, my query was, if you are doing 𝐿C in cases of C microdeletion, and after that, because the chances of inheritance will be there, so do you recommend the PGD for those?
No. Counseling should be done beforehand only, ma'am. I mean, why do we go into these intricacies? जरूरत ही नहीं है. A and B में sperm नहीं मिलेंगे आपको. 99% मिलेंगे भी तो छोड़ देना. C में मिलेंगे और लिखवा लो husband से, I have underwent this situation and I may inherit it and I am mentally prepared for that. That's it. But carrying out PGS for that, looking at those Y chromosome, see, ma'am, when we are looking for numerical aberrations, it's very easy. But when we are looking at C microdeletion, we can do this definitely, and nobody's stopping us. But now getting
so the counseling is basically
so you have to make a primer for Y chromosome C del primer banega. You spend 2 lakhs more on that, and the chance is nearly 100%. All sperms are having this problem, no? Then in case a man had it been an X related, तो issue बच सकता था. पर man में तो अगर लड़का होगा तो होना ही है उसके अंदर. That is the problem. So we don't advise it.
Okay.
I think I'll say stop here because I have to rush to the hospital. Somebody is just coming.
Thank you.
Start somebody's cycle.
Thank you so much, sir.
Thank you.
Thank you
so much, sir.
Thank you so much.
Dr.
Left in the chat box.
Thank you, sir. Thanks a lot.
I will try to answer them in the group. And just a small apology from our side. We don't share any recording of CRs, and we do not personally mail you any document. We are going to post all the documents in the dedicated WhatsApp group. Please take those documents from there. And thank you so much for joining us. Thank you so much. I can see my seniors. Respect to all and my friends and juniors.
Thank you so much, everyone.
Thank you.
Thank you.
God bless you guys. Thank you.